This is something that we are certainly just beginning to understand. First, in patients that progress on CDK4/6 inhibitors, we have not really known completely the prognosis for these particular patients. So there are emerging data that suggests that for patients who have progression on a CDK4/6 inhibitor, that their prognosis actually might be quite poor with standard endocrine therapy agents. And this would be, for example, with a drug, a standard hormonal agent with a drug like, say, tamoxifen or another aromatase inhibitor. What we are really in need of are the data on whether we should continue CDK4/6 inhibitors past progression. And then the second, which is really critically important, is to understand the mechanisms of resistance that are actually driving the growth of the tumor in these women that have progressed on CDK4/6 inhibitors. And so that, to me, is the most important area of research right now. And I think as we go forward, what we're going to see is that clinical trials are going to be really focused on these different subgroups. For example, we have data, of course, with the drug alpelisib, and alpelisib is a drug that targets tumors that harbor PIK3CA mutations. It's already shown efficacy in hormone refractory groups of patients, and we're awaiting data on the efficacy of alpelisib in this group of patients that have progressed on CDK4/6 inhibitors. Some very few patients have been treated thus far in the SOLAR-1 trial, and so we're waiting data from the BELIEVE trial, which will give us data on the optimal treatment for patients with PIK3CA mutations. So we think in general that as women progress on CDK4/6 inhibitors, or their tumors progress, we're going to need real, if you will, individualized strategies to address the different mechanisms that may develop.